Hello, good afternoon. My name is Kristen Snyder, and Jennifer McWayne is here with me. And today I have the pleasure of moderating and speaking in this webinar entitled Supportive Care in Vascular Anomalies for the American Society of Pediatric Hematology and Oncology. Before we begin, I just have a few housekeeping items. Please note that all participants have been muted for the presentation this afternoon. I would like to direct your attention to the chat room on your screen. Please use this chat room to ask any questions, which I will then direct to Jennifer and myself at the end of our presentation. You can also use this area to let me know about any AV issues or technical difficulties that you are having during the presentation. As I mentioned, in addition to myself, Jennifer McWayne, a physical therapist, will also be speaking today. Jennifer is the clinical specialist for the lymphedema program at Mary Free Bed Rehabilitation Hospital here in Grand Rapids, Michigan. And we will be toggling back and forth as we go throughout the webinar. Oh, also, there'll be cases. So please answer by clicking the most appropriate answer, and we'll see where those answers pop up. So today, we will review the classification schema of vascular anomalies, discuss cases of patients with vascular anomalies requiring a variety of supportive care needs, review techniques, supportive care methods, and treatments used to provide supportive care for our vascular anomalies patient population. As many of us know, vascular anomalies encompass a broad clinical phenotype, and although infantile hemangiomas are much more common than any other vascular anomaly, not all vascular anomalies are hemangiomas. Historically, any vascular lesion was called a hemangioma, and naming of that hemangioma was dependent on the vessel or the channel size. Capillary hemangioma, strawberry hemangioma, or cavernous hemangioma. Until recently, definitions of vascular anomalies have been inconsistent, and biologically and clinically different lesions have been grouped together. With more precise classification, the traditional naming methods of vascular anomalies has also changed. What was traditionally called a cavernous hemangioma is now called a venous malformation or a capillary venous malformation. What was called a lymphangioma or cystic hygroma is now called a lymphatic malformation. And what was called arteriovenous hemangiomas are now arteriovenous malformations. Vascular anomaly is the umbrella term that covers all vascular tumors seen on the left and vascular malformations seen on the right. And while there are many vascular tumors, today we will focus just on infantile hemangiomas. Infantile hemangiomas are the most common vascular tumor in infants and occur in 5 to 10% of Caucasian infants, with a predilection for female and premature infants. These are benign and self-limited, and a watch and wait approach has been applied over the years. They grow rapidly in the first 6 months of life, reaching 80% of their size by 5 months, and then go through a slower growth phase, months 6 through 12. In one study, only 3% of lesions had documented growth after 9 months of age. However, deep hemangiomas typically grow later and longer. The natural history of infantile hemangiomas, as I mentioned, is one of benign, self-limited, and watch and wait approaches have been applied. However, complete involution isn't always complete. Sometimes residual fibrofatty tissue remains, scarring, especially if there were ulcers, atrophy, redundant skin, discoloration, and telangiectasias. Histology is significant because these tumors possess a glucose transporter isoform 1 positivity, and other markers also, which are not found in normal dermal or subcutaneous capillaries or other vascular tumors. And first-line treatment for infantile hemangiomas is now propranolol in doses up to 3 milligrams per kilo per day, divided BID to TID. timolol maleate 0.5% gel-forming solution can also be applied topically, BID to TID, to macular or superficial hemangiomas less than 1 centimeter in size with good results. In our outpatient clinic and in clinics around the country, propranolol treatment is initiated in otherwise healthy infants with infantile hemangiomas. And I should first note that the following slide defines how we provide propranolol in our clinic. Other clinics may vary. Propranolol is initiated in healthy infants 40 weeks gestational age and at least 4 weeks of age. As long as there's no family history of arrhythmia or sudden death and no maternal history of connective tissue disease or lupus. Propranolol is initiated at 1 milligram per kilo per day orally, and in patients less than 6 months of age, it's divided in every 8-hour dosing, and if greater than 6 months of age, it's divided in every 12-hour dosing. Vitals are obtained 1 to 2 hours following this initial treatment, primarily to look for bradycardia and hypotension. And 7 days later, this dose is increased to 2 milligrams per kilo per day orally and divided either by Q8 or Q12-hour dosing. Vitals are again obtained 1 to 2 hours following that treatment in the clinic. Once the patient's at goal dosing, I see them monthly until about 6 months of age and then bi-monthly, maintaining their propranolol dose for their weight. Treatment duration is usually for about till 12 months of age, and I wean over a week. Complications of infantile hemangiomas include ulceration, infection, bleeding, pain, disfigurement, and compromised organ function. This compromised organ function can include high output cardiac failure, airway compromise, suggested by stridor, hoarseness, or noisy breathing, visual field defects, hepatomegaly, and hypothyroidism. Now we're going to continue this dialogue with some cases. The first case of this webinar involves infants. In the first case, you receive a call from your ophthalmology colleague regarding a 1-month-old female infant who she was referred for a glaucoma evaluation because of a port wine stain suggesting Sturge-Weber syndrome. She reports that the patient's lip is becoming more and more puffy, and she thinks this is actually a hemangioma. In addition, the patient has a prenatal diagnosis of a possible Dandy-Walker formation of the cerebellum that was noted on an ultrasound. When should this patient be seen in your clinic? Give you a few more seconds. Based on the rapid growth at 1 month of age and the fullness of the lips with risk for ulceration, this patient should be seen in less than a week. Also thinking about this patient, what other studies might be needed? Few more seconds. The correct answer is all of the above, and we'll talk about this in a minute. So this patient was seen within a week, and on presentation she had an extensive right-sided facial hemangioma and ulceration of her lip. Her parents reported irritability, poor sleep, and poor feeding. In a similar case, a 2-month-old developed a diaper rash unresponsive to usual treatments for diaper dermatitis. In addition, She had a prenatal diagnosis of hydronephrosis, ectopic ureter insertion, and a small left pelvic kidney. Now, what if I also told you that she had a large proliferating hemangioma of the labia, perineal area, and buttocks with vulvar ulceration? What is the diagnosis you're thinking of here? Okay, so the answer here is pelvis, and we'll talk a little bit about both these now. So these two cases remind us that infantile hemangiomas can be associated with a variety of other anomalies. In the first case, our patient has Facey syndrome, one of the most well-described vascular neurocutaneous disorders, which should be thought of for any infant presenting with a facial segmental hemangioma, where the P in Facey's is associated with a posterior fossa anomaly. Dandy Walker in this case was cerebellar hypoplasia. The H, a hemangioma of the head or the scalp greater than 5 centimeters in diameter. The A for arterial anomalies, especially cerebrovascular. The C, cardiac anomalies like coarct of the aorta. And E, eye anomalies. And then the S, supraumbilical raphe or sternal clefting, that you can see where the red arrow is directing you. Diagnostic criteria have been formalized and include a large, greater than 5 centimeter segmental infantile hemangioma and one other major criteria or 2 minor criteria. Similar to Facey syndrome, patients who present with hemangiomas over the lumbosacral region and lower body make us think of lumbar, sacral, and pelvis syndromes, and to assess for anomalies associated with these lower body hemangiomas. In a recent study, 50% of infants with infantile hemangiomas overlying the lumbosacral area were found to have an associated intraspinal abnormality. When we think about treatment of infantile hemangiomas, we suggest treating those which have a high risk of ulceration and/or disfigurement. Hemangiomas more apt to ulcerate or cause disfigurement include those that are rapidly proliferating, those that are segmental in nature, like our patients, those that are lumbosacral or involving the perineal areas. The first patient required hospitalization and admission due to dehydration, failure to feed due to pain, and ulceration of her lip. She was started on propranolol at 0.5 milligrams per kilogram per day, divided Q8 hours, initiated on IV fluids, and treated with analgesics and morphine for pain while inpatient. An OG was placed to supplement oral feeds by bottle, and Neosporin was used as an aid in healing of her upper lip erosion due to the hemangioma. Propranolol was titrated up to 2 milligrams per kilo per day and prednisolone initiated. MRI, MRA, and echo were performed, and she also had accompanying cerebrovascular anomalies. By discharge, she was able to take full feeds with improvement in her ulceration and planned for prednisolone taper over a week. The ulceration improved prior to discharge, and she was discharged with weekly follow-up. The second case of infantile hemangioma ulceration we discussed today is a patient with pelvis syndrome. She presented with multiple sores of the perineal area. She too was initiated on propranolol, which over time was increased to 2 milligrams per kilo per day. And her ulceration was treated with gentamicin ointment, applied TID, and liberal use of Z-Guard paste, which is white petroleum and zinc oxide. This is wiped off when the diaper is soiled with stool, but not when she urinates. She was treated with Tylenol for pain every 6 hours as needed, and the ulcers were smaller and less deep at the 7-day visit. And I should note that this picture is not that particular patient's ulcer. Ulceration is the most common complication of infantile hemangiomas, and most studies of ulceration care span the pre-propranolol era. Early white or gray discoloration of an infantile hemangioma, as seen in the top photo here, often heralds impending ulceration. Ulceration is exquisitely painful and increases risk for infection, bleeding, and scarring. These lesions may cause poor feeding and lead to irritable sleep. Ulceration typically occurs in deep, rapidly proliferating hemangiomas or superficial segmental hemangiomas, particularly those of the anogenital area. Secondary infections may be associated with cellulitis, osteomyelitis, bacteremia, and sepsis. And small ulcerated hemangiomas may respond to topical antibiotics or thin hydrocolloid dressings, but larger ulcers may benefit from pulse dye laser treatment, oral antibiotics, IV antibiotics, and analgesics. Prevention of ulceration is obviously desirable, and this requires meticulous and gentle skincare and avoidance of trauma to the area. Once ulcerated, the goal is to re-epithelialize the tissue. Treatment similarly involves meticulous and gentle skincare as well as topical antibiotics, sometimes oral or IV antibiotics, barrier creams, and non-stick dressings such as Vaseline impregnated gauze, and gentle debridement with saline soaks 2 or 3 times a day to prevent crusting, which prevents re-epithelialization. Long and colleagues evaluated 77 studies of ulcerative hemangioma treatment in a systematic review. 1 randomized controlled trial, 30 observational studies, and 46 case reports, which consisted of 1,200 patients. Propranolol use resulted in complete healing in 97% of patients, with healing ranging from 10 days to 10 weeks. Similarly, pulse dye laser used in 200 patients resulted in 100% wound healing in 2.8 to 10 weeks. There was 1 randomized controlled trial that randomized patients to observation versus propranolol, and in that study, propranolol treatment resulted in healing in 8 days versus approximately 27 days in the patients that were observed. Topical timolol was also used in patients with ulcerated hemangiomas, with healing reported in 2 to 6 weeks, but complete resolution was not reported. Importantly, though, topical timolol should be very cautiously considered. Timolol is 10 times more potent than propranolol, and studies have reported the presence of timolol in the urine in 20 of 24 patients, 80% of patients tested. A concise chart, which I've included in this slide deck, is adapted from Drs. Liu and Frieden and lists benefits of various wound care dressings, antimicrobials, analgesics, and methods to expedite healing of ulcerated hemangiomas, similar to that mentioned previously. So as you recall, vascular anomalies are divided into vascular tumors and vascular malformations. We've discussed briefly some complications seen with infantile hemangiomas, the most common type of vascular tumor in children. Now we will focus on the vascular malformation side of the vascular anomaly spectrum. These include capillary malformations, lymphatic malformations, lymphedema, venous malformations, arteriovenous malformations, and arteriovenous fistulas. We will begin by briefly discussing venous malformations. These, as you know, are congenital, but not always evident at birth, and most are sporadic. They consist of slow flow, ectatic venous channels, and they can be deep, superficial, localized, diffuse, solitary, or multiple, and they do not proliferate. They grow proportionately with the child. However, they can suddenly appear for the first time with trauma, intralesional bleeding, sepsis, and hormonal changes. And they may occur alone or in combination with other malformations. Our next case involves an active 21-year-old male college student. He was known to have a large venous malformation of the calf, as noted on the image in the right, where you can see a tortuous and distended vein in between the white arrows. To him, this is unsightly, and he presented looking for recommendations for treatment. What is your greatest concern? Similarly, The patient on the right is a 17-year-old female who presents with an extensive venous malformation. She also complains of cramping, heavy, and irregular menses, and she takes an estrogen-containing OCP and has an implanted estrogen-containing device in her arm. What are you most concerned about for her? I think that's good. So obviously for both these patients, the most correct answer, the most worrisome outcome is that of a DVT and a subsequent PE. So in the case of our 21-year-old, he actually presented years prior with shortness of breath and dizziness after a few days of studying and then participating in a pickup game of basketball. He was found to have a PE and was treated with heparin and long-term warfarin treatment. A full hypercoagulability workup was otherwise negative, and he was recommended at that time to also wear compression garments, and he was intermittently compliant with that. In a retrospective review of 128 patients with venous malformations, nearly 70% had complications causing morbidity, including pain, swelling, thrombophlebitis, bleeding, and limb length discrepancies. Hypercoagulability is associated with increased lesional size, intramuscular involvement, and female sex. Presence of phlebolysis and elevated D-dimer levels strongly suggest ongoing coagulation, at least within the lesion. This is termed localized intravascular coagulation, or LIC, and is associated with varying degrees of decreased fibrinogen levels, elevated D-dimer levels, and platelet counts in the normal to decreased range. LIC most commonly is seen in large or extensive venous malformations, and those with the most significant LIC have the highest risk of coagulopathy. These patients are at risk then of venous thromboembolism and pulmonary embolism, certainly if there was a connection with the deep venous system. Members of our Vascular Anomaly Special Interest Group conducted a survey of vascular anomaly providers to better define risk factors for coagulopathy and management recommendations for patients in the peri-procedural settings. Survey results have been presented at both the 2016 ASPHO VA-SIG meeting held in Minneapolis and most recently at the International Society on Thrombosis and Hemostasis in Dublin in 2018. This survey highlights variability of practices across the largest vascular anomaly centers in the US and Canada and recommends creating standard operating procedures for this vascular anomaly patient population. The next case is of a 3-year-old with a large marginal vein associated with diffuse venous malformations of her left leg musculature and capillary malformation of her back. She has undergone coiling and embolization of the marginal vein. She remains on anticoagulation due to prior thrombus with D-dimer levels ranging from greater than 4,000 at birth and 500 to 1,000 while on anticoagulation, when the lower limits of normal are less than 500. She was referred to physical therapy early in infancy for compression therapy and has been regularly fitted for new compression garments with her expected growth. The family reports today that her new compression garment does not fit properly and they are not using it. How should you counsel this family? What would you recommend? Would you recommend that the family contact their therapist for reassessment of the garment fit? Or not worry because she's on anticoagulation and so this will prevent further thrombosis? Perhaps you should suggest an over-the-counter TED hose to the family. Or perhaps the family should give it a longer trial, maybe a week, to see if the tolerance of the garment improves. I would say that we should recommend that the family contact their therapist nearly immediately, same day, for reassessment of the garment fit. Not that they can get in the exact same day, but they should contact their therapist on the same day. And I want to highlight this case because it's common to hear that a compression garment is not fitting properly. These garments, though, can take weeks to be approved by insurance companies and then often 6 weeks to be custom made. Jennifer, do you think that you could give us some pointers and some education on compression therapy for venous malformation?
Yes, I'm happy to. So with compression therapy intervention, what we're typically doing for venous malformations is we're fitting them with, like in this case, it's a 3-year-old, so they're likely going to have to be fit with a custom thigh-high stocking. Until they're about age 10, they're not going to typically fit in anything that comes in an over-the-counter size. So we're going to fit them, and of course, a big part of that is educating them in use and monitoring for fit issues. We aren't usually putting nighttime garments on these patients, but sometimes on individual cases it can be useful to have something on at night too, but it won't be the same compression garment. There's other options for that, and we'll get into that more when we talk about lymphedema. We're also monitoring for lymphedema that can develop in areas of long-term venous insufficiency. And our therapy goals are to lessen the intravascular coagulation, improve symptoms and appearance, diminish edema, protect against minor trauma. So we're using compression therapy for venous malformations, lymphatic malformations, and lymphedema. And these have to be individually tailored so that we have a graduated pressure garment that provides compression gradient, moving the fluid from distal to proximal. Used early, and when I say continuously, I mean daily. Not everybody has to have something on at night. That's an individual determination. And just looking at what the cost of these garments, it's typically under $100 if you can use an over-the-counter garment. If it's going to be custom, it's likely going to cost them more than $300. So just talking about some of the, in looking at the prescription of that actual garment, materials and construction are two things that are considered. So the material, looking at the extensibility, the elasticity of it, there are short stretch or high stretch fibers. The fatigability of it, the ability for it to return to the original shape after strain. Wear resistance to mechanical, thermal, and chemical exposure are all things to consider. So for example, if there's rubber versus cotton in those materials, it's going to react very differently to the use that especially highly active kids are going to put on these garments. Construction is also a consideration about whether it's weaved where the threads are at right angles to each other compared to a knit that has loop stitches, and even within knit it can be a circular spiral knit versus a flat knit, which would make the difference of whether you're going to have a seam on the garment and how many shapes are able to be surrounded. So if there's a lot of lobule types of shapes, you're likely going to have to go with something that's going to be seamed and more flat knit to accommodate those shapes. Single versus double strands is important in that if there are concerns about the garment binding, we would go with more of a double-stranded material. And there's many options you can add to garments, including padding, such as around the malleoli. You can go with toe caps, where you're getting individual compression on the toes as opposed to anything that would just squeeze the toes. That's usually not well tolerated. Squeezing the toes together is what I'm referring to there. In hand pieces, you can have a glove with full fingers, a gauntlet with partial fingers, or a hand piece without finger compression. There can be zippers. There are silicone borders to help prevent slipping, and there's multiple different fastening systems. So the most important thing about fitting these garments is that we have to measure very accurately. And for most patients, the best time to measure is first thing in the morning when the edema is down most significantly. Really, this is probably one of the main areas that developing expertise in being able to troubleshoot using garments and having that experience with seeing how various patients in various conditions have reacted is an important part of what we do in matching the right garment to the right patient. So it's so important to keep that pressure gradient. If you have an off-the-shelf garment and the patient's in the low end of the range distally and the high end of the range proximally, you could be losing that pressure gradient, and that could cause stasis and cause more issues. So we use a variety of manufacturers so that we can try to find a garment that really does match that patient's measurements, so we're making sure we maintain that pressure gradient. And frequently we will have to go to custom to make sure that we're avoiding stasis. So donning education is so important with these patients, teaching them techniques for getting the garments on properly. If it's just sliding on in a matter of seconds, it's not enough compression, and so they need to learn to expect it's going to take 3 to 5 minutes to get this garment on typically. There are many accessories we can help them get, non-slip mats, rubber gloves. There's various slip-on devices that can help get those garments on. And then we're looking at the weave or the knit of the material. We want to see some stretch in that material. We want it to appear uniform. Garments shouldn't be painful to wear in typical circumstances. We really, RSV is really the only circumstance where we may be working through that unusual type of pain to get through development of tolerance to a compression garment. Any redness or irritation that lasts for longer than 10 minutes needs to be addressed. Sometimes we can have them wash and dry the object over, or the garment over a larger object, such as thumbs tend to be a problem with gloves, and we'll dry them over a larger pill bottle. We may have to switch to a different garment using different materials in construction. It's very important to work with a therapist who's certified in fitting garments, or many DME vendors are also certified in that, and frequently we may go to the compression garment vendor representative to help solve tricky patient issues. And of course, a big part of checking the fit of that compression garment is it effective at controlling their edema?
Thanks, Jennifer. So we're going to move on a little bit to lymphatic malformations. These have historically been referred to as lymphangiomas or cystic hygromas. They may be microcystic, macrocystic, or combined. They vary in size from small vesicles which leak or bleed to massive lesions associated with mass effect or overgrowth. Like venous malformations, these grow proportionate to the child, but trauma may result in rapid growth from internal hemorrhage. These too are associated with frequent infections which can be severe and may require longer antibiotic treatment regimens or prophylactic antimicrobial use. Treatments may include sclerotherapy, surgery, and medications such as sirolimus. Our next case is a 13-year-old female with a lymphatic malformation involving the left buttock and lower back with extensive involvement causing mass effect on the pelvic organs. She initially presented to our Vascular Anomalies clinic after a chronic history of cellulitis and oozing related to her lymphatic blebs, multiple ED visits, and frequent use of narcotics for pain. Within 6 months of treatment, her episodes of cellulitis had drastically reduced and her visible lymphatic blebs improved. However, her mother called in between exams and reported the development of intense abdominal pain. And an ultrasound at her local hospital was consistent with complete replacement of her left ovary by a lymphatic malformation. What is on the differential for this patient? A radiologic reading error, a lymphatic malformation in the location of her left ovary, an ovarian cyst, or all of the above? You guys are so smart, all of the above. So this case illustrates the importance of the clinician and the radiologist interaction. As you may recall, this patient's lymphatic malformation distorts and has mass effect on our pelvic organs. Midline examination by ultrasound shows a cystic structure, which really could be bladder, but is actually the left ovary with a large cyst. The bladder is better seen pushed rightward. A known lymphatic malformation is present in the left hemipelvis, remote from the left ovary, on her MRI. When ordering imaging, it is always helpful to make notes in the order such that the radiologist and the technologist can better anticipate changes in your patient's anatomy due to vascular malformations. In addition, this patient's ovarian cyst likely represents one of the known toxicities associated with sirolimus, namely increased risk for ovarian cysts and menstrual cycle disturbances. Our next cases reflect two cases of primary lymphedema. The first is that of a 2-month-old boy with history of hydrocele and swelling of his right foot and minimally his left, without other findings, but with a family history of similar swelling in both his father and paternal uncle. The second case is that of a 12-year-old girl with obesity who developed right foot swelling without trauma 6 months prior. She had no other findings. She was placed in walking boots at the onset of swelling, which resulted in atrophy of her calf musculature, but she continued to wear that boot since it was the only shoe that fit her. Both of these patients have lymphedema. So let's walk through the classification pathway for primary lymphedema together. First, starting at the top, we ask if the patient has a known syndrome. And in the case of both of these patients, the answer is no. Similarly, we ask if the patient has a systemic or visceral involvement. And the answer to that is no as well. Or in the yellow box outlined in orange, is there any disturbed growth or cutaneous findings or vascular anomalies which would suggest KT, Parks-Weber, Proteus, or Cloves? And again, in the case of both patients, the answer is no. Does either patient have a second row of eyelashes? No. And now in the green box, we ask if this is congenital onset. In the case of our first patient, the little boy on the left, his foot swelling was noted shortly after birth, and it involved his lower limbs. His family history is significant for similar swelling in his father and his uncle, and this suggests a diagnosis of Milroy syndrome. Considering our second patient, she developed the swelling of her foot at approximately age 12, so this is later onset. And her lymphedema involves her lower limbs only, and her family history is negative, and lymphedema is unilateral, suggesting late onset lymphedema of the unilateral type. Primary lymphedema affects 1 in 100,000 people younger than age 20. It occurs shortly after birth or in the first 1 to 2 years, that it's termed Milroy or Milroy-like, and that constitutes 10 to 25% of primary lymphedema cases. The later onset, termed Meggy or Meggy-like, consists of 65 to 80% of the primary lymphedema cases. Milroy disease is characterized by lower limb lymphedema present as pedal edema at or before birth or developing soon after. Swelling is usually bilateral but can be asymmetric. The degree of edema can progress, but in some instances can improve, particularly in the early years, and it may be associated with hydroceles. It is associated with autosomal dominant inheritance. However, 10 to 15% of those with gene abnormalities do not show lymphedema symptoms. Meggy disease is hereditary lymphedema which appears later, usually at or after puberty, affecting the feet and the ankles, and associated with autosomal dominant inheritance. And pathophysiologically is associated with dilated lymphatic vessels, with impairment and drainage. Jennifer, do you think you could walk us through the stages of lymphedema and help us better understand how to provide the best supportive care for this population of patients?
Absolutely. So this shows what the stages of lymphedema are. So stage 0 would be there's no swelling. And that's usually what we will refer to somebody who's had lymph nodes removed for staging of cancer. They don't have swelling, but they are at risk because of the lymph nodes being removed and disrupting that pathway. Stage 1 would be presence of some pitting edema, reversible, meaning that it will reduce with some elevation, and there aren't usually skin changes. The skin is still usually soft and supple. In stage 2, the skin is starting to become hardened, and the pitting reduces because those fibrotic changes in there don't allow that pitting to happen anymore. And we call this spontaneously irreversible, which just means it doesn't reduce with elevation any longer. Stage 3 is that of what is referred to as elephantiasis. There are skin changes. Papillomas appear to be sort of like blisters that are filled with that lymph fluid, but with a much thicker dermal tissue over that as opposed to a true blister. They're at risk for fungal or streptococcal infections. They ulcerate, they'll form cysts, fistulas can form, and then lymphorrhea is very common when the tissue will weep a serous fluid even when a wound isn't present. There will be an extreme increase in the lymph volume. So how we treat this is a program called Complete Decongestive Physiotherapy. And we base our program on the Lymphedema Association of North America, as well as the National Lymphedema Network, maintain best evidence-based practice position papers about what's the best way to treat lymphedema. And this complete decongestive therapy is still considered to be the gold standard in treating lymphedema. So we have certified lymphedema therapists who have been through this 135-hour training course where you do 40 hours pre-classroom and then 95 hours in the classroom. This is in addition to their degrees in PT, PTA, OT, or CODA. We don't use massage therapists in our neck of the woods, but I understand that there are some massage therapists that have been certified in this as well. What we don't use are people who've gone to a weekend course and don't have certification. I think that this is one case where a little knowledge can be a dangerous thing, and so it's not something that we have allowed to have as part of our treatment program. There are not pediatric specialty courses or certification in this program. So the components of a complete decongestive therapy program are manual lymph drainage, compression therapy, decongestive exercise, skin care, and education and training of the caregiver and patients, and I'm going to talk about each of these. So the manual lymph drainage technique is a sequencing where you're clearing a traffic jam. Think of lymphedema as a traffic jam, and if we just squeezed at the end of the traffic jam, all we would do is bear on those cars together. We have to get the fluid moving at the area closest to where that blockage is. So we start the treatment up closest to the venous angle and then move from proximal to distal. And we'll treat at healthy lymph nodes as well first to help direct that fluid towards where we have healthier lymph node pathways. So these pictures just show some of the typical pathways that we use with upper and lower extremity lymphedema. And of course, it's very important that we understand that anatomy and the direction of those lymph vessels. In the picture of the lower extremity pathway, you can see that there's actual diagonal in the lower extremity there, and that understanding that diagonal and where that runs is an important part of being able to produce that manual therapy correctly. So we also use lymphedema compression bandaging. This is a picture of an arm and a leg bandaged. So these bandages are what we would call short stretch bandages, and they're very different than ACE wraps. ACE wraps are not recommended for lymphedema. The short stretch bandages produce a high working pressure and low resting pressure, where ACE wraps are the opposite. So they're applied to create that pressure gradient through multiple layers working distal to proximal. Underneath that bandage, there's a layer of stockinette to help absorb perspiration, and then a layer of foam padding. And we use that foam padding to also build up around lobules or odd-shaped limbs to make sure we avoid any binding. Coban is used as part of that bandaging in some centers now. It sticks to itself so it can help to reduce slipping down. But we use compression bandaging during phase 1 of therapy such that the patient has it on all the time except for when they're in treatment or they take it off for bathing. So let me differentiate that, what I mean by phase 1 compared to phase 2. Phase 1 is when we're seeing them in therapy. And so we may be seeing this patient typically daily for anywhere from 1 to 6 weeks, depending on the severity of lymphedema. So the reason for that compression bandaging is that it reduces filtration, increases reabsorption, improves efficiency of the joint and muscle pump, prevents reaccumulation of the lymph fluid. As we massage that fluid out of there, we don't want it to be reaccumulating back in there. It can help to break down and soften scar tissue and fibrotic tissue, and it provides support to those tissues that have been stretched out and lost elasticity. So there is an alternate to bandaging. There's some Velcro fastening devices out there, and sometimes we use those for improving compliance, but we really do try to use bandaging always as first and best practices. Those Velcro wraps can be easier for patients to don and doff, but like I said, they really show better results when we can have that compression bandaging that's more custom fit to the limb. So some pediatric considerations with bandaging is it may not be possible to bandage in infants, the size and development and strangulation risk with bandages. So careful application and monitoring is very important. A lot of those kids can't tell you if they're feeling numb or discomfort, and we don't recommend wrapping toes at all until after age 2. And it's very important that bandaging not interfere with growth and development. So phase 2 is when we're done with the patient coming to us for treatment and we're getting ready to discharge them. Phase 2 would be considered their home program that they're going to continue on with after discharge. After the limb's decongested, they're fit with a daytime compression garment. Compression socks and sleeves are meant to contain the swelling and keep the limb in its smallest decongested state, not to reduce the swelling. The compression garments are worn daily for maintenance. Typically, we're going to have to use a custom garment until the child is about 10 years of age. We're usually using 20 to 30 millimeters mercury of compression under 4 years of age, but lymphedema can sometimes require going to a 30 to 40 millimeter mercury compression in adolescents and older. So this slide just shows some examples of some patients in compression garments, and I've included the cost of this because the cost is a significant issue with these patients. Very few insurance companies actually cover compression garments. So it's part of our consideration, and as they grow, they're going to be replacing these, and they will wear out too. So with compression garments at night, sometimes we can switch to these quilted types of garments for these patients. This is better for kids when we're worried about that a bandage could come loose and cause a tourniquet problem. So these are frequently used for children 1 year of age or under. You can see that there's been more effort from these companies to produce garments that look more like pajama pants to help reduce the social stigma of having to wear compression devices. This is an example of some head and neck lymphedema garments. They can go from encapsulating the whole face to just localized areas as it's needed. This shows some garments that can be used for chest lymphedema, for genital lymphedema. This demonstrated a $921 pair of bike shorts, but that's specifically a compression garment. But we will frequently help families find bike shorts and then get these swell spots that they can add to those bike shorts to help control costs, and have gotten good results out of that. There are different programs out there that can assist with cost of compression devices. This is an example of lymphedema resources that has a garment and treatment fund that somebody can apply to. There are vendors that offer special pricing programs. For instance, there's one vendor that will offer garments free under age 2, and then they have percentages off as the child grows older until age 18. Decongestive exercise is another part of the program to help improve lymph circulation based on the understanding of anatomy and physiology, improve the venous return, and optimize joint and muscle pump. So deep breathing is an important part of these exercises because that thoracic duct runs through the diaphragm. Deep breathing can actually act as a siphon to that system. Exercises in infants can be simple and passive. We do avoid strenuous exercise. They're done slowly and in a muscle pumping fashion, and we have the patients wear the compression garments when doing exercises.
So our next case is a patient who underwent therapy and had really good results. However, I received a call one night from this mother, the mother of this patient, with known lymphedema, and she reported that her daughter was complaining of tightness of the affected leg. And upon further questioning, Mom said that the girl was afebrile, and upon inspection of her daughter's leg, she noted redness and swelling. And in this case, what would be the most likely diagnosis? Normal lymphedema because there's no fever, a tick bite, cellulitis, or a deep venous thrombosis. So the most likely diagnosis in this case is cellulitis. In a recent study published in the New England Journal of Medicine, investigators reported an observational cohort study of children with primary lymphedema whom they followed for cellulitis. Of 128 children included in the study, the first episode of cellulitis was confirmed in 38 patients at a median age of 11.5 years. 29% of those patients then went on to develop a second episode of cellulitis at a median of 9 months after their first episode. And then another 26% had 3 or more episodes, a median of 10 months after their second episode. While 45% of patients were hospitalized at least once for signs of severe or systemic sepsis. Cellulitis and lymphedema is something that is to not be ignored. In the case of our patient, she did have cellulitis and was started on oral cephalexin with an excellent response. An interesting review of the top 10 myths regarding the diagnosis and treatment of cellulitis suggests that skin that is red and swollen without a fever or high white blood cell count can still be cellulitis. Authors recommend performing a raised leg test where the patient holds their legs straight at a 45-degree angle for 1 to 2 minutes to monitor erythema. Erythema superimposed on lymphedema will persist upon elevation of the leg in the setting of true cellulitis. Antibiotic decisions should be based on the presence or the absence of purulence, risk factors for MRSA, and local antibiograms. However, most commonly, cephalexin treatment for non-purulent cellulitis can be appropriate. Bactrim for MRSA coverage, if at increased risk for MRSA, is also appropriate, with the caveat that providers select the best empiric treatment based on resistance to oral MRSA treatments in their community. And finally, lymphedema itself is a risk factor for cellulitis, and it is also associated with treatment failure independently. Jennifer, to mitigate risk for infection associated with lymphedema, could you just update us on the recommendations you provide families?
Sure. So skincare is an important part of the education we provide patients. The lymph accumulation leads to increased diffusion distance in the interstitial spaces, so the skin can become dry and can crack and makes it easy for bacteria to crawl in there. Skin is naturally acidic, so we recommend low pH lotions, and this is just some examples of some lotions that could be used. So in the education, we're recommending they avoid extreme temperature changes. Vasodilation means more swelling. Also avoiding anything that your body is going to send more blood flow to help tissue heal, including insect bites, needle pokes, blood pressure, cuffs, sunburn, deep tissue massage. And we always recommend that they wear compression when traveling by air. That decreased atmospheric pressure is correlated with increased swelling. And we've had many patients who had never experienced swelling before have it become triggered when flying. And remember, too, that the risk for lymphedema does not go away over time. Some other treatment options I just want to mention is that there are intermittent mechanical compression pumps out there. The FDA has approved them. They will advertise that they mimic MLD, the manual lymph drainage massage, but it's not consistent with the anatomy, physiology, and pathophysiology. It squeezes the limb. Concern is that it could remove water, leave protein, and create neural insufficiency. It's unpredictable by research standards on who gets better, worse, or stays the same. When it's combined with a complete decongestive therapy, there's some contradictory results. More results show better improvement in the arm, but not in the leg, and even that is marginal. Lymphedema management using manual therapy similar to myofascial release techniques can be helpful to reduce fibrotic tissue, range of motion and flexibility training. And there's a new device that we've been using. It's now called the LymphaTouch. It's negative pressure, sort of like cupping, but it's much more controlled. Cupping can produce up to 2,000 millimeters mercury of distraction pressure, where this device we can control between 0 and 250 millimeters mercury of that distraction, but opening up that interstitial spaces, and there's also a vibration mode on there to help decrease scar tissue, but that can help to direct lymph flow and open those tissues up. We've actually had very good outcomes. It's improved our outcomes significantly, such that at our center, we've had the device for almost 2 years, and we have 4 of them now because they're very highly utilized in the clinic. This is just some examples of some outcomes before and after. These patients were involved in approximately 3-week treatment programs. Their reason for lymphedema is variable, but these cases were related to having lymph nodes removed. This is an example of somebody who was born with a congenital issue, and really in these pediatric cases or congenital, our outcomes are a marathon, not a sprint. It's going to take more time to get that fluid out of there. So getting them independent and having them stick with that, you're likely going to see better results more in a 6-month period as opposed to 3 or 4 weeks. This is an example of a child that we've been treating since infancy, and you can see that his swelling looks to be quite controlled there. And I put a picture of what I would surmise that his limb would look like without treatment. There's also drug therapies that can be used. Diuretics are a concern for us because they remove the water and leave the protein. Well, if the patient's not on a diuretic for like a blood pressure reason, we'll usually ask the doctor if we can reduce the diuretic, because having that fluid in there will help to move that protein out of there. Daflon has been trialed for post-lymphadenectomy patients. They have shown a 6.8% reduction as opposed to a 60% reduction with the CDT. So I still believe that the complete decongestive therapy has a better outcome. Drug therapy to increase tissue proteolysis or stimulation of macrophages takes 11 years to get the same effect as 4 weeks of the complete decongestive therapy. The statin is currently in a phase 2 clinical trial looking at whether that can repair and reverse lymphedema disease in mice, and results are pending on that. Microsurgery, which would be a lymph node transfer or a lymphadenocvenular bypass surgery, is being done with better results, but typically most surgeons, their first criteria is that the patient would have had to fail complete decongestive therapy before they're willing to take them down this road. And the other part of it is that it doesn't eliminate the need for the phase 2 self-management program. These patients are still expected to use compression, learn self-manual lymph drainage, and continue with their exercises.
Thanks so much, Jennifer. So in conclusion, we want to talk a little bit about opportunities to improve knowledge in vascular anomalies. And it's important to hone your knowledge, especially because now vascular anomalies will be represented on the pediatric hematology oncology boards. You can also consider joining the ASPHO Vascular Anomalies Special Interest Group, or ISPHO, the International Society for the Study of Vascular Anomalies, which currently meets every other year, or consider attending the biannual Controversies in Vascular Anomalies Conference, which will take place in New York City, May 17th and 18th of this May. In addition, I'd like to draw your attention to the ASPHO Knowledge Center, particularly the ASPHO recordings, including previous annual meetings and prior webinars such as those listed here, and the Herndon Project webinars in vascular anomalies. I want to take a moment to thank Jennifer McWayne. Thank you, Jennifer, for sharing your expertise with us today, as well as leaders and members of our ASPHO Vascular Anomalies Special Interest Group. Patients, both my own and those of my colleagues, who have taught us so much and from whom we still have so much to learn. And the ASPHO for providing Jennifer and I the opportunity to give this webinar today, and the ASPHO community at large. We are very happy to take any questions with the time that we have left. And you can type them in the chat box. As we were kind of giving our talks, there were a few questions that popped up. So one of the questions had to do with propranolol and vitals, and whether or not I've seen significant vital changes due to propranolol, and if I've had to make any medical management changes because of it. And I would say probably 1 in about 200 patients had a lower heart rate due to the propranolol given at 2 milligrams per kilo per day. And that was when it was divided Q8 hours. And we stopped that patient's propranolol at about 1.5 mg per kg per day. But that was the only vital issue that we saw. Typically, when I check heart rates, I want to make sure that they are always well above 100. And with the exception of that one patient that was closer to about 105, they always have been. The other question that came up was, how does one measure the gradient of the compression garment?
So that's a very good question, and there really isn't a tool out there that allows us to get any type of objective measurement. And this is one of those areas where it's you develop a skill for looking at seeing that there is some stretch to that material and seeing that stretch look uniform over the garment. And probably the biggest way that we are judging whether that garment is effective or not is taking the circumferential measures to make sure that we're seeing that that swelling is well controlled.
Thanks, Jennifer. Another question that has come up is, when starting patients on sirolimus, do you also start Bactrim prophylaxis? And in my clinic, I do. And I know that there are other clinics that do not use Bactrim prophylaxis. And I think that that's up for debate, and there are ongoing research studies right now looking at the need for Bactrim prophylaxis with sirolimus. And sometimes, as you know, we use sirolimus at higher trough levels, maybe a 12 to 15 trough level, and sometimes we're using sirolimus at a much lower trough level. And I think we may find that it may end up being trough level dependent whether we use Bactrim or not. But again, that's still up for debate. Any other questions out there? Jennifer, I have one more question for you. You mentioned that what qualifications there are for a lymphedema therapist, but how can we find somebody like you in our town or at our hospital, in our hospital system?
So the National Lymphedema Network and the LANA Lymphology Association of North America both do on their website maintain lists of therapists who have been through the certification course, and you have to show proof to them that you've been through the certification course to be listed on their website. So that's probably one of the best, those two sites are probably one of the best places to go to start searching for certified lymphedema therapists.
Perfect. And you can see the LANA website is on one of our previous slides too. All right, guys, thank you so much for attending. We really appreciate you listening in.